Let's start with the Q&A. First one is for Dr. Gangi. What are tumor deposits? How do they differ from tumors? And do the tumor deposits, predict a worse outcome?
So tumor deposits can mean a variety of different things depending on if your surgeon told you they saw them or if the pathologist is saying that they saw them on your final pathology report. From the surgical perspective, tumor deposits are essentially small spots. Think something as small as a salt granule that we might see on the different surfaces of your abdominal cavity or elsewhere. And that essentially is typically suggestive that in an abdominal primary, meaning a pancreatic or small bowel primary, that you have what we would call peritoneal disease. It just means that there's kind of free-floating tumor cells that have moved outside of where the tumor had started. And it doesn't necessarily portend a worse prognosis. It certainly can, depending on how many deposits we see. It might mean that the tumor has been there longer than anticipated and is more advanced. In some scenarios, it limits the surgical options for that patient, because if there's many of them, then you can't necessarily clear all of the disease, but if they're limited and confined to a particular area, then you can still remove those. If it's on your pathology report, it means that the tumor deposits weren't clearly visible to the naked eye, and in that scenario, we wouldn't have known that they were there, but sometimes it means that they're not in a lymph node and they're not in the original site of the tumor, but they've, again, moved their way out, so that might put you at a higher risk for developing additional tumor deposits in the future.
Okay, great. Anything to add from the other panelists? No. Okay. Two more. Dr. Auerbach, and we brought Dr. De Rivero to come help you out. How should we think about whether to choose PRRT, Lutathera, or Captum first after liver resection? How do we make this decision?
Yeah, I don't have a clear answer because there is no clear answer. The sequencing of therapies, systemic therapies, that is, once the disease has metastasized, is not clear, and any sequence is pretty much fine at this point. It really depends on the individual patient situation, their personal preferences, their overall health, and a discussion between the oncologist and the patient of what the next line of treatment should be. A bit of a frustrating answer, probably, but the good news is that giving one therapy doesn't exclude giving another therapy, so all the options that are available can be given at some point. In what sequence, that is an open question at this point.
Okay. Yes, I completely agree with you. Whenever we talk about the options for neuroendocrine tumors, one of the things that we always say is not a one-size-fits-all. So we make recommendations based on the specific clinical characteristics of the patient. That said, when the question is after surgery, you know what the recommendations are in terms of other systemic therapies. And I think that's something that I usually discuss with the surgeon, because sometimes the surgeons may tell me, you know, the amount of tumor that was resected after the surgery. Sometimes, and maybe Dr. Gangi can clarify, is that not always all the tumors can be resected. And sometimes there may be some tumors left behind, and it's like, what do we do with what is left behind? And sometimes it's a decision that we usually discuss as a group to understand after surgery, you know, number one, what is the growth rate, whether the tumors are stable, so maybe continue watching with scans, and the continuation of somatostatin agonists, either with lanreotide or with octreotide. Another comment that I would like to make is that the question of adjuvant therapy after surgery. And I think, as discussed earlier, we don't have a straightforward answer with that. There is an ongoing study, is part of one of the cooperative groups that want to understand what is the benefit of adjuvant capecitabine temozolomide in patients with pancreas neuroendocrine tumors once the liver metastases were resected. And that's something that as of now is not a standard. We usually do not recommend, but there is an ongoing study to really answer that question. I don't think we have any data on adjuvant PRRT, and I don't think we have that, and I think it will be difficult to answer that question. But in terms of systemic therapies after surgery, first we need to understand how much tumor was left behind, and what will be the follow-up in terms of skins and whether we are going to continue with somatostatin agonists or not. Usually my own approach, if my surgeon tells me, well, all the tumors were resected, unless it's a functional tumor, I usually like to watch with skins. Now, if there is some tumor left behind, I usually follow with skins, and then I would like to understand what is the growth rate of some of the tumors in order to then guide me what will be the other options. But I think overall, the standard management of follow-up in terms of volume of tumors and growth rate, that can also dictate what treatments we have. If we have a patient that have large volume disease that is more rapidly growing, maybe we are more inclined for capecitabine temozolomide, and because we know that that can shrink tumors, whereas lutetium, more stabilization of tumors. Kind of like I say, I know it's like giving a long answer, but I think the decisions are based, and it's not like a straightforward answer sometimes, but I think that a lot of the decisions is based on the very specific clinical characteristics of the patient. I don't know what you guys, Dr. Gangi or... Yeah.
That's great, thank you. Okay, question for Dr. Gangi. After finishing PRRT treatment for metastatic NETs, is surgical debulking of the liver still a good option?
Surgical debulking of the liver is always a good
I
option.
knew it.
If you ask a surgeon.
Spoken like a surgeon. The PRT doesn't preclude you from being a surgical candidate necessarily. If the reason that we didn't suggest debulking prior to surgery was the volume of disease that you have, meaning there's many deposits in the liver that we can't treat, and after PRT it still looks that way, then you may still not be a candidate. But the PRT itself would not prevent you from being a candidate from surgery. It can make the surgery a little bit more complicated, secondary to some of the inflammatory reactions that you can have adjacent to the tumors that responded to the PRT potentially. But short of that, you are still a candidate.
Great. All right. Dr. Auerbach, I have my own question. I'm going to sneak it in. How many PRTs can you give to a patient? Like, how many times can someone get it?
Well, so the standard of care is to give for 4 cycles. There is not that much data on giving additional cycles. That said, there is data in patients that respond well to the initial 4 cycles of PRT. And the definition of a good response, again, is fluid, but we want to see at least 12 months of stable or improved disease before the disease has gotten worse to consider somebody for what we call salvage PRT. Most places that give salvage PRT give an additional 2 cycles. And then, you watch. Usually the response in patients that had a good response the first time around, they have a good response the second time around, although not as good as the first time around. And you can repeat that pattern. If they had another good response, you can give another 2 cycles. Of course, the more cycles you give, you have to be more concerned about potential side effects, the most serious one being MDS, myelodysplastic syndrome, which can then transition over to leukemia, which is a very serious disease. So it's really how many cycles, there's no clear answer, but we've had patients that have received multiple rounds of salvage PRT, and again, if it worked the first time, it usually works the second time and third time.
That's great. Dr. Del Rivero, how many have you given?
Okay.
What's the most?
I mean, I'm in complete agreement with Dr. Auerbach. I think if you see a benefit of lutetium within the first 4 cycles, the standard is to give another 2 cycles as long as the insurance companies are able to prove it, because I think that's kind of like one of the situations. I think most nuclear medicines would like to give more cycles. It's just that sometimes insurance authorizations, we need
Always
to
the rate limiting step, unfortunately, yes.
Yeah. And, but currently, I would like to mention there is an ongoing study. It's called the NET Retreat, meaning that after 4 cycles of lutetiums, there is an additional 2 cycles to kind of like, we already know that there is a benefit of that, but that can prove the benefits of giving extra cycles of lutetium, so that way here in the United States and Canada, that should be available for patients. But that's kind of like one of the, as Dr. Auerbach said, I think if there is a benefit in the first 4 cycles, the likelihood that there is going to see a benefit is still quite likely. That I do believe that most nuclear medicine physicians would like to give extra cycles, but it's just the insurance that sometimes is a rate limiting issue. But hopefully with the study, the retreat, we'll have that information that will allow us to provide more cycles of lutetium.
That's fantastic. Thank you. Okay, Dr. Auerbach, how has Y90 changed over the years? Some docs think it's drastic. Other radiology specialists say it has improved greatly. Will Y90 now prevent PRRT later?
So there's 2 different forms of giving Y90. One is as PRT, where it's pretty much nobody does it anymore because the side effect profile is just not as good as with lutetium-177. But there's a different Y90 treatment which is done by interventional radiology, where you directly infuse beads that are coated with Y90 into the liver to target the tumors in the liver. And that's all I'm going to say because I'm not an interventional radiologist. So that works well and is being used very, very frequently. So not to confuse Y90 PRT, which is not done anymore pretty much, and interventional radiology Y90, which is being done.
That's great. Thank you. Dr. Gangi, we sometimes hear doctors say you have a heavy tumor burden. What defines a large or small tumor burden?
There's no specific number, and it depends on in relation to what part of the body we're talking about. With respect to the liver, typically a heavy tumor burden is if you have more than 50% replacement of the liver with tumor and the distribution is in both lobes. Remember I showed that picture of the liver with all the 8 parts? So there's kind of a right side and a left side, and if the distribution is greater than 50% in both sides, that's typically considered a heavy tumor burden. But there is a little bit of variation, and then those deposits, tumor deposits that you mentioned, they can also be kind of described as heavy or not, and that might be dependent on if they're located in just one part of your abdominal cavity versus throughout the abdominal cavity. So there's no specific cutoff number, but it's a little bit dependent on what we're looking at.
That's a great answer. I mean, I think that the best way to understand it also is not every tumor is the same. So for one person, what could be a heavy tumor burden, for another person is not. So it really also depends on what kind of tumor you have and how fast it's growing and how aggressive it is, yeah. Okay. This is a great question. Dr. Auerbach, can you have alpha or beta PRRT after regular PRRT? And which is better?
So yes, you can. And which is better? That's what we're looking at, so we don't know.
Which do you think is better?
I don't know. And, that's research in medicine is not straightforward. It's you're comparing one thing to another. You have to wait until you see changes. It's not like a physics experiment where you get the result. We try to be scientific, but a lot of it is trial and error and takes time, and we have to wait and find out.
All right, wait and see. Thank you. All right, Dr. Gangi, I feel good. Can I live with my PNET, which is stage 4? Why do I need surgery now? The surgery would be remove part of the liver, part of the pancreas, gallbladder, and spleen.
I'm assuming you require a distal pancreatectomy, and the recommendation to have the surgery now might be because you are currently a surgical candidate, meaning we feel as though we can get rid of all of the disease now. Sometimes these tumors can grow. We don't necessarily know how quickly they're going to grow, but the bigger the tumors are and the more of them there are, the bigger the operation. So can you live with it? Absolutely. But the recommendation for surgery now versus later typically is based on some of those concerns of the rate of growth and what a downstream operation and your eligibility for the operation might be.
Okay, thank you. This is a question for all the panelists, but we'll start with Dr. Auerbach. How often should NET patients have a gallium-68 or a copper-64 scan? Annually? And should you do a CT or an MRI in conjunction with the functional study?
The current guidelines, if they exist, the recommendations are to do imaging about every 6 months, and you can alternate between doing a PET scan or PET CT and anatomical imaging. It also, again, it will depend on the individual situation, how aggressive the tumor is, whether the patient has symptoms that are of concern and need to be worked up, and how long they've been on their journey with the neuroendocrine tumor, how stable it is from prior imaging. But usually, at least when we do PRT, we recommend doing imaging about 3 months after the last cycle, because there can be something called pseudoprogression, where the disease initially gets bigger before it gets smaller or stabilizes. So the first scan at 3 months, I usually recommend doing a PET CT, because you get both the anatomical and the molecular information. And then if that looks good, then at 6 months you do another scan if that looks good, and that can be a CT scan only or MRI. And then do the next scan 6 months later, so a year later, and then if everything looks stable, you can transition to imaging twice a year. But again, those are rough kind of guidelines. It will depend on the individual patient. But the general approach is to alternate between PET CT and CT or MRI.
Okay, thank you. Do you have any other thing to add? Okay. We have 9 questions in 9 minutes. All right. So, Dr. Gangi, for surgery, how do you know if the surgeon is a true NET specialist? For example, if a surgical oncologist operates on 60% of patients with NET cancer, is that a specialist?
Similar to the tumor burden question, there's no strict cutoff. I think, kind of like I mentioned in my talk, if they said they've never seen or done this, then you don't necessarily always want to be there first. But yes, certainly if they operate on 60% NET patients, I think you could consider that person well-versed in treating neuroendocrine tumors.
Thank you. Okay, how large does a tumor need to be seen on a dotatate scan? What would prevent a tumor from being seen on the scan?
So size is a problem for imaging in general. For PET imaging, if a lesion is smaller than, well, to be conservative, smaller than a centimeter, and you don't see a signal, I usually say that too small to be reliably characterized by PET. On CT, you will see lesions that are small, down to a couple of millimeters. MRI, especially in the liver, will pick up millimeter-sized lesions, so it depends on the imaging modality. But for PET imaging, if it's negative, but it's smaller than a centimeter, then you don't really know.
Okay, great. Dr. Gangi, Whipple, open or robotic?
Whatever your surgeon does best. Truly, there's no
That's a good answer.
there's no data in terms of one being better than the other. In some scenarios, patients might hear that the time to recovery is shorter for a robotic Whipple. The bottom line is you still get an incision to get that specimen out. It might just be located in a slightly different location. Sometimes the size of your tumor and the involvement of the adjacent vessels or lymph nodes might preclude you from being a candidate for a minimally invasive operation. So basically it goes back to that trust your surgeon to be telling you that this is the best approach.
Great, thanks. Dr. Del Rivero, when should MRIs be taken instead of PET CTs?
think that goes a little bit on the question of how often do we do PET-CT versus CTs or MRI. Usually my standard approach is like I follow my patients with anatomical imaging studies, either a CT or an MRI. And if I see any changes either on one of the scans, then I would like to confirm it with a PET, a gallium scan, or even another patient, an FDG PET scan. We know that MRI is better for characterization of the liver tumors, and that's, Dr. Gangi may agree that even to determine any surgical intervention or any surgical plan, an MRI may be better to determine or to characterize liver tumors. The only scenario where I recommend a PET-CT over an MRI or a CT scan is in patients that have only bone lesions or bone metastases, because they're better seen on the functional imaging modalities compared to the CT or MRI. But that said, in terms of follow-up as well, any 4 or 6 months, depending on the volume of disease or where the tumors are located in terms of frequency. But yes, my PET-CT scan, I usually do it once I see anything on the CT or MRI that needs to be further characterized, unless there is bone metastasis where PET-CT scan or gallium scan is better in those situations.
Thank you. Okay, Dr. Gangi, pancreas surgery and liver resection. Do you combine them at one time, or you split them up into 2 separate operations?
If we can combine them into one, we typically will.
Yes. Okay, these are 2. We can do it. We're going to get there. All right. This is very creative. 3 questions on 1 card. Okay. So what does it mean when a doctor says something is a hemangioma, not a NET? How can they tell? And would you do a gallium-68? All right, we'll start with that one, and then we'll do the 2 other ones.
I'll take that since it's an imaging question. Usually, with the imaging modalities we have, you can tell whether something is a hemangioma, which is a benign finding. It doesn't require an intervention. From something that's not a hemangioma and potentially malignant. Yeah, it's usually clear from imaging.
Okay, it's clear. Good. Which is better, gallium-68 PET or copper-64 PET? And then go back to the alpha versus beta and just, come on.
Yeah.
Let's do this today.
Sorry, vendors, but there is a difference. Whether it's clinically significant is debatable, but I read these scans every day, and copper-64 has its advantages because it has a longer half-life, so it's easier to distribute, etc. But the positron decay of copper-64 is only yields about 30% of the decay yields positrons, whereas from gallium-68 decay you have, I forgot what the exact number is, 80 or 90% of the decay yields positrons. So you get more counts with the gallium-68. More counts gives you a nicer image. We compensate for that with the copper by imaging longer. So that usually creates an image that's almost equal. But personally, I prefer gallium-68.
You're so smart. Okay. Can surgery be done after PRRT?
Yes, we already said that, I think.
Yes.
But yes again.
As you can see, she's a yes woman. Okay. Absolutely. Okay. This is the second time we're saying preclude today. What could preclude surgery? Embolization, other treatments?
I think that's a very patient-specific question. There's no particular thing that necessarily precludes you from having surgery unless there's been downstream complications from that particular thing, or tumor location, vascular involvement, carcinoid heart disease, your overall health. All of those things are considerations, but there's no one therapy that you could say off the bat would preclude you from being a surgical candidate.
Yeah. Histotrypsy. You had it? Easy. Histotrypsy. Histotrypsy question mark.
Yes. Histotrypsy question mark. Exactly our thought. So it's currently just been demonstrated to be safe, but in terms of efficacy and benefit, we still don't necessarily have data on that. We currently recommend in patients who have not had the therapies that we know work to potentially consider those therapies if they are available to them prior to proceeding with histotrypsy.
Yeah, of course.
Yeah.
That's why you're here. Yeah.
So I think there is a lot of limitations with histotrypsy, and I think there is a lot of more education that needs to be done around histotrypsy. The limitations around histotrypsy is that you cannot treat all tumors, and it has to be within certain depth in order to be treated. So it's kind of like something that we need to educate, because I think that there is so much out there in terms of propaganda about histotrypsy, but we need to understand what the limitations are about histotrypsy. And is one thing that I always say, the histotrypsy cannot treat all tumors, just because the way it is, it has to be within certain size, within certain depth. And if somebody has a lot of fat tissue, that can also has the limitation of that, because it needs to go more in depth in order to address the tumor. Moreover, I think we still need to know the long-term, understand in terms of seeing more patients or treating more patients with histotrypsy in order to understand the benefit. We still don't know. And I'm sorry? Because of safety. No, just because of safety, but not efficacy. So that's kind of like one thing we know is safe. The histotrypsy we know is safe, then it can be done in patients, but still don't know the long-term efficacy or how well it can work. And that's kind of like the questions that we still need to answer. That said, we still need to treat patients in order to really understand and answer that question. Moreover, some of the information that is on about histotrypsy, and that may be a research question, is that it seems that in order to be more efficacious, it requires a certain immune system or immune cells around the tumor in order to have some efficacy. And what we know is that even in neuroendocrine tumors, we still don't know that question, because we believe that a lot of the neuroendocrine tumors are more immunologically inert. So that said, that's a research question, and it's a lot of things that we still need to answer.
Thank you. Well, this has been one of the best question and answer panels I've seen. Thank you, panelists, for that. That was really good.
Thank you, moderator.
Thank you. This is great.